The main things that you're going to want to be palpating on our shoulder is obviously going to be our clavicle. So let's hear it. So palpate in the supraclavicular fossa, getting closer, guys. Supraclavicular fossa. Okay, you can palpate out superior border of clavicle, and you can palpate out inferior border of clavicle. Okay, that clavicle is going to connect with our acromion for our AC joint. Nice fat clavicle. Fat isn't pH fat.
It's that osteoblastic production after Olympic lifting.
So here's our AC joint, okay? So we have the distal end of the clavicle, and then the proximal end of the acromion. So I'll have all you guys palpate as well. Remember that acromion then wraps down on its distal lateral aspect to become the spine of the scapula, right? So then you can palpate the spine of the scapula. Okay? So you can also palpate over from the clavicle, and you can palpate your sternoclavicular joint, which is right here. Okay? Obviously our larger muscular landmarks we can see, and it's nice when you have someone who's actually muscular because it makes it much easier to see the borders. But we have our anterior deltoid, right, that's running down. We have our middle deltoid and our posterior deltoid. Okay, so marking those off. So if you were to be evaluating for any deltoid insertional tendinopathy, which is pretty rare, but seen it a handful of times. You're going to be down in here. These are anterior. And then our posterior, which we will use as a landmark for what structure?
Quadrangular space?
Not quite. Yes, we do, but there's one more that's specific.
Posterior deltoid.
The superior lateral brachial cutaneous nerve that's piercing through the superficial fascia and about this region here, then wrapping over the lateral aspect of the shoulder. Okay. So from here, let's go into a... So remember, you're going to want to be in a neutral position, or a supine, because this is going to be neutral, a supine position, which is going to help take that biceps and move it more anteriorly. Because if you watch biceps, right, this is our bulk of biceps, which is then going to come up and form our tendon. When you go into internal rotation, what happens is that whole humerus rotates, and I'll show you on the ultrasound after, but it's really, really hard to see where the bicipital groove is and the biceps tendon when we're in this internally rotated position, which actually helps to bring out what structure for our injections?
Super.
Yeah, our supra and infra and thesis on the greater tuberosity, right? Because they were rolling and taking what was lateral and moving it a bit more anterior, so it becomes a little bit easier to palpate. So from here, you can do your Lippmann's test to find our
Bicipital tendon.
Right, and his is nice and large, which is always good. So, right in here is our biceps tendon, okay? So then from there, you'd be able to feel that. You could move this into an externally rotated position and you feel it move over here. So for you to find your subscapularis enthesis on the lesser tuberosity, and then come internal and we can find the bony attachment of supraspinatus and infraspinatus. Okay. Our supraspinatus, remember, is running deep to the trap here. It's going to run underneath the acromion, and then it's going to come out and attach onto basically this portion here. And so from this position, basically this bony structure in this region here is roughly where our supraspinatus is going to insert. And then infraspinatus is actually, a lot of people think it's inferior. It's actually posterior and slightly inferior. And so this here is our infra or supra, and then our infra is going to kind of be in this region here. Because these two are going to blend together with infra attaching kind of first and then supra attaching afterwards. Do you have a question?
Can you put an S and an I? Nice.
And then when we go into our externally rotated position,
Ding, ding, ding.
infraspinatus. Or sorry, subscapularis.
Tender.
But now they all go on to form the rotator cuff. Is that right?
Correct.
Okay.
Yeah.
So they have like individual attachments, but they're all attaching onto the rotator cuff, which goes onto encompass.
So no. So rotator cuff is just a term to describe the four sits muscles, subscap, infra, teres, and supra, that control rotation of the arm. So they don't insert onto the rotator cuff. The rotator cuff is just a term for all four muscles. So the supra and infra fascially blend together. Teres does not. Teres is separate, and then subscap is separate but actually still attached. And I'll show you, subscap actually crosses over the bicipital groove and has a fascial attachment onto the greater tubercle.
Darn YouTube video. They're saying they all blend kind of into the same fascia or tendinous sheath. Is what they're.
Well, kind of, yes, and that's more so with
just those
supra
two.
and infra.
Yeah.
But teres not really.
Okay.
And then again, subscap is on its main attachment is on a completely different part of the bone, right?
Yeah.
Because that one's coming from the anterior aspect of the scapula, inserting onto the lesser tuberosity, versus the supra and infra coming from the posterior aspect of the scapula and inserting laterally on the greater tuberosity.
Yeah.
So teres major would be in here somewhere, onto like,
Yep.
and then minor would be like
Mine would be back in here.
back in here, right?
Yeah, and we can scan and show you that.
They'd be inferior to where we are currently. Like they'd be lower.
Definitely. Yeah. For accessing the joint, I take a posterior approach when under ultrasound, and I take an anterior approach when doing palpation based. And that's just because I think you can palpate bony structures a little bit better to figure out where you're at in terms of getting intra-articular. So what are our three?
Coracoid.
Yeah.
Acromion.
Which coracoid is right here. Okay, coracoid, acromion,
Anterior part of the acromion.
and then we're also,
The most prominent part of the humerus. Well, I guess that would
which
be.
again, a lot of people come in like this, it's just this. You're doing this to feel where's the most prominent portion. So here, 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 you're going to triangulate and you're going to find the middle. Right there, which again is always going to be superior to where supra and infra insert, because supra and infra insert outside of the joint capsule. So you can't access the joint capsule if you're going through supra and infra. So will be superior to that.
Is Zach's musculature making it so that it's more superior than what it would be for others? Is deltoid? Because Isn't for other, many others more
I don't think so.
anterior? No, it's
Mm-mm.
pretty typical.
And then from now, you'll slightly have to adjust with more muscular because it's if you have like the actual humerus here, the musculature could be built out more anteriorly and anterolaterally than laterally and posterior, and so it will change slightly, but it's not going to be like a huge like we're 3 inches different or anything like that. So then from here we can insert. In which direction do we generally want to insert?
Lateral.
We usually want to come this way. The reason for that, you can go this way. I like going this way because generally I know if I'm out this way and I hit bone and I inject and I'm not in the space, I know that I have to go medial, right? And I can continue to walk until until the needle gets inside the joint capsule without really risking damaging the labrum, okay? If you come this way, the labrum is situated in that plane. And so your first pass needle could go all the way and you could just be gummy and be going through the labrum the whole time, okay? The labrum's a not very well vascularized structure, which makes it more difficult to heal.
Okay. You'd have to be really far off to come to the lung, right?
You have to be very, very far off.
Okay.
Yeah. Because again, remember, lung, so we have to have our ribs, which are all the way over here. Well, we're going to come up this way. But if you're coming from top, it's a bit more.
Because apex is right there.
Apex is going to be here. But when you're coming anteriorly here, you'd have to be very, very far off to.
You go through a lot of good stuff to get there.
Yeah.
You have to go through a lot of good stuff.
Miss the ribs.
You'd have to go between ribs.
Yeah.
And what about the bursa? Because doesn't the bursa lay in between?
Yeah, so the subacromial subdeltoid bursa is basically going to run in this plane here, and it's going to be deep to the acromion, and it's going to lie in between your supraspinatus and your deltoid.
Okay.
So that's why it's called the subacromial subdeltoid bursa, the SASD. Yeah, and I'll show you that where that would be under ultrasound.
But so when doing the shoulder joint, not so much of a concern because it's more lateral, more superior than where we're going to be going. Or if you
well, technically, when you are injecting the enthesis of supra, you need to pass through the bursa to get there. Yeah, but it's not a major issue if you put a little bit of fluid inside of it.
a bursa.
Yeah. Okay. Any questions? Yeah.
Tendon injection enthesis is through here.
Yeah. So our long head of biceps attaches where?
The labrum.
Right, and it attaches onto the labrum on the anterior aspect, the anterior superior aspect of the labrum. Okay. So one of the ways that you can attempt to get close to that is this is without ultrasound guidance, is by coming through what's called the V. So your acromion has this little V shape in here that you can feel when you're coming along trap, and obviously deep to trap is supra, and you will come up to a spot where this is the internal hook of the acromion. Okay? That can give you access because from here you can go inferior and you can drop down either onto the glenoid rim or the head of the humerus. And so with the injection or the needle, once you advance the needle and hit bone, what you can do is you can take the patient's arm and you can passively do IR and ER. Because if you're on the head of the humerus, what you'll see your needle do will be huge movements, right? Because the needle is on top of the head of the humerus and the head of the humerus is rotating. If the needle is on the glenoid rim, which is what we want, you'll still see a little bit of movement because the needle is passing through supra, and when you do this, supra elongates and shortens passively. You'll still see a little bit of movement, but it won't be big movement, okay? And so from there, you know that you're on the glenoid rim, and then you can walk it anteriorly as you do injections to basically try and treat the insertion of the labrum onto the glenoid rim, and by doing that, you will hopefully hit the insertion of the biceps tendon on the labrum, which would be our slat tear. Good.
So that's another access point to an intra-articular if you had to.
Yeah. Yep, because if you come here and you get onto the head of the humerus, you'd be intra-articular. I don't like doing that because then your needle hits the cartilage and that can damage cartilage, obviously. And then just one more thing for the body to have to heal in that process. Okay?